I've got some nice questions that have come up now, Russell, regarding the section earlier on the guidelines. Hi, I heard Symbicort is PBS approved for symptomatic relief. Is that true?
Symptomatic relief in
Oh,
a known asthmatic.
yeah.
So you've got to have asthma.
Mm-hmm.
In fact, the Canadian guidelines are a bit more specific on us. Their equivalent TGA was mild persistent asthma. In other words, they were saying you couldn't use it at the early stage for initial diagnosis. I think we, with the retrospectroscope, should have said the same. So I don't think it's a diagnostic tool. I used to have someone in my practice who would use Symbicort as a diagnostic tool for asthma. And we just could not get that behaviour to change over the 10 years he was with us. So I don't think Symbicort should ever be used as a challenge to see whether what they respond, that's asthma. I still think you've got to have your diagnosis right, and it's not for post-viral, it's not for anything else, it's just for asthma, or obviously COPD for the right patient. But.
Yeah, and I think the important thing is, again, it's that getting that proper diagnosis, as Peter emphasised. I think it's been emphasised repeatedly here. If you don't get it right at the beginning, you never know what you're dealing with down the line, and it's your best chance to get the diagnosis right at the beginning. Because once people are on medicines, it's very hard.
Yeah.
I've got this question here. Back to PRN, ICS, LABA. Using so-called mild episodic asthma. Give me now no fewer mild and episodic. Is that really appropriate? Or actually, are most people persistent? And in fact, this is actually not an appropriate approach. What's your thought on that?
I think what we thought was mild episodic is actually, in reality, a lot more persistent than the patient perceives, and certainly that they let on to us. And I still use the three main questions: how much reliever, are you getting any nighttime symptoms, and if you had to modify your life to match your asthma, you get a yes to any one of those three, then to me, it's not a matter whether it's good control, mild control. Are you in total control or not? If you're not in total control, what are we doing wrong? What's different? So I think a lot of those mild episodics, in fact, are a lot more persistent than they or you really think. And for the last 12 months, for that category and a new diagnosis, I've actually been going a little bit off label, and we've spoken about this previously, but I've been using Pulmicort 200 just once a day as a once daily, and that's not licensed, but gee whiz, they've been doing quite well. And now that PRN is here this week, I mean, my option to that, to be totally legal, may be a PRN with one dose a day every day of their life. When they clean their teeth in the morning, it might be something new that I'm going to pick up and run with.
Okay. I've been asked a question: is the OPC program easy to use with the practice software? Any installation required? And then there's the next one about patient privacy issue. So is it easy to use, Joe?
Yes, it is. It's very easy. So I was happy with the OPC with my IT and coming onto the computer. The privacy issues I was allayed and happy with. So it's very, very easy.
Okay. And maybe I'll answer a little bit on the privacy issues. The software currently works on best practice and medical director. And what it does is it extracts tables that do not have patient identifiable data. So those are the only things that are extracted, and they're hosted on our server. In fact, those of you with eagle eyes might even have seen the server behind me. And so it sits here in Brisbane. There is no patient identifiable data on there. The only linkage back to the patient is what's called a hashed and sorted IHI. So it's the individual health identifier that has a one-way algorithm to hash it. So technically, if you hashed everyone's IHI in the country and had their names and address, you could get to those IDs. So on top of that, we have what's called a salt key, which is practice unique, that basically adds a practice element. So we can only decode who that patient is back in the practice. So that's why we have to run software in the practice to mail any patients or text them or email them, and also to relink the patients in the reports. Otherwise, we can't do that. The data is then available for research, but we remove that hashed and sorted IHI for the research purposes. And we have RACGP approval for that data to be used for research. Hence, me able to show that data on the asthma control earlier, the exacerbations earlier, which is exactly the same process as we have in the UK and the United States, where we do primary care quality improvement as well. The other thing that we are moving on to do is, because much data, most of you do not code everything, and I fully understand why. You write nice long free text notes. And so we actually have a redaction system that in practice removes obvious identifiable data. And then on its way to us through the cloud, it removes 3 million other potential names, addresses, etc., that might have slipped through on our initial redaction before it gets to our server. So that's the patient privacy issue sort of covered. It is always a big issue. We've been running this in the UK for 15 plus years. And so, yeah. I've got a question here. How long does the adrenal dysfunction persist after withdrawing the endogenous steroid? Do either of you want to have a go at that, or would you like me to do that one? That silence suggests you want me to do it. Go on, Joe. Go on.
No, that's okay. I'm not okay in terms of what the adrenal insufficiency for, say how long. But I mean, if they're using it for less than 2 weeks, I'm not too worried about sort of tapering it down.
Absolutely. Now it's more the long-term use. And we don't really know. I mean, we never had the opportunity before we got the biologics to really get people off long-term OCS. And it's only now that we've got those that we're really starting to see there's a good proportion, and I can't tell you the exact proportion yet, although I do know the answer, who over a year, their adrenal function, once you hit 5 milligrams, they're good down to 5 milligrams. But once you hit 5 milligrams a day, which is about the same amount as your adrenals normally make, that's when things start to go crazy. And you cannot judge on symptom grounds. You have to actually get formal adrenal function testing. And it looks like even a cortisol is not enough, but we'll have more data on that down the line. So I can't say more than that, but it is a specialist issue to solve. The lady who was rather obese, should she be tested for sleep apnea?
That's an obvious question. Yeah, I think that's a good idea.
Yeah.
Absolutely. And they haven't got to be obese to have sleep apnea. So
no, and that's important. And one of the things that we do find in our audits in Australia is you are kings of the world at diagnosing sleep apnea. I find rates in the UK of sort of 1% or something. I can't remember one of your practices, Joe. How high was it? It was really quite high.
Was it up to like close to 20 or 15?
Yeah, I think it was around that sort of level, wasn't it? And I'm going, what's going on here? But of course, it's. Now is the UK? Are you over-diagnosing or the UK under-diagnosing? What do you think?
Potentially, we got more access to diagnosing it.
That was very diplomatic. What do you think, Russell?
I think the changes last year to pull back the testing was probably appropriate, but it has made it on occasions a little bit more difficult depending on how militant and politically correct the sleep provider is. So I think we are more aware of it in Australia. Sorry, I can't say that. I've not practiced overseas. I would hope that we're actually more aware of it. And I think personally, because I've got it, I'm even more aware of it than I used to be.
Yeah. So I've got a question here. Why on earth, it didn't say why on earth, it says why are, but I thought I'd add the on earth. On earth, SABA's available for purchase OTC in Australia. Maybe we'll ask Cynthia that one when she joins us in a bit. But what do you guys think?
I think the chances of us ever reversing that is absolutely impossible. I'm not sure how many pharmacists are online, but I know the push from pharmacy is incredibly strong that would resist that move because they would feel very much that we're denying people necessary emergency medicine, and that is a hard position to argue that's wrong. There's financial and retail perspective that comes into that. I mean, the Ventolin shortage and in fact the Flixitide shortage during COVID has been quite astounding. I didn't think anybody was only using Flixitide. Everybody had been converted to Seretide, but we won't go there. But yeah, the medicines that were out of stock, and luckily in our town, I didn't hear any direct reports, but some of the reps were telling me people were selling 10 Ventolins to a non-asthmatic who just walked in and asked for it. Now that's scary, but unfortunately it does happen in isolated cases. In South Australia, I think Kerry could fix this up, but I think in '94 when we brought in the national schools policy, we actually had to change an act of parliament in South Australia to be able to put Ventolin in a first aid kit in the school. You could put a spacer, you could put a big nice poster on the back of the door, but you weren't allowed to put a Ventolin. So I think the idea is that it will ever go back to S4. I just don't think that could ever happen in Australia now that it's out of the cat's out of the bag.
I'm here.
Cynthia, I'm sure you're going to have something to say on this.
I'm here. Yeah, I think it's a complex issue given that it is as it is now, and I think many pharmacists would recognise that there is an issue with SABA being so readily available to patients with asthma, but also pharmacists are in a difficult position because then they've got to make the call to deny someone a SABA. When they are the only place that they're going to be able to get that SABA from. So I think it is a challenging situation, and that's why I always feel that with the guidelines and with everything, it would actually be great to have them developed in such a way that they were actually practical, in a practical sense, helpful to pharmacists when they are in this situation where they do have to make decisions about SABA, when they do have to review patients to identify those that might be mild or those that might be severe, because it is a challenge. But it's very difficult for a pharmacist to deny someone a SABA when they come in and they say that they need it.
Yeah, I absolutely agree. I mean, we had the asthma card in New South Wales 20-something years ago, which was an attempt to try and address SABA overuse, but it failed because you just couldn't deny a person who said they needed the medication. It just wasn't a safe and ethical thing to do.
It's interesting, in the UK, where SABAs are only available on prescription, but can be provided by a pharmacist in an emergency. The actual rate of that happening is very, very, very low. But I do recognise the challenge. It's one of the things that does surprise me about Australia. Going back to the lady with the fixed airways obstruction, potentially either long-term severe asthma or hidden COPD, although she'd never smoked. The questions I've had are all about passive smoking. So, is it due to her mother smoking? Is it due to her husband smoking? So, do you think that would be enough of a smoking challenge to give her that degree of airways obstruction? Joe, you're looking cynical.
I don't know enough to make that opinion. I don't have an opinion.
Russell?
I would have thought no, but it reminds me of an anecdote told in Brisbane some 3 or 4 years ago by a very, very esteemed professor who used to be at St George, and he'd actually had a major change in his vocational direction in life, and he explained to the group why, and he said that he just turned the age that his father died of COPD at 67 years of age, and his father was a non-smoker, but he said his mother smoked 60 a day and was still alive at 92. And he basically said, my mother killed my father, and I've reached this point in life, and I've made a decision for my lifestyle. But obviously it does happen, but I'm not sure at what level the degree of passivity becomes active.
Okay. I've got a question from me, I think, about ethics approval before running OPC. So for quality improvement itself, no ethics approval is required. We do have RACGP accreditation for the audit program, but to use the data for research, yes, it does. So we have a separate ethical approval from the RACGP for that use of the data. In addition to that, before it can be used for any specific projects, we also have a second committee called ADEPT. That's a global committee that does all this for a lot of different types of work like this, that reviews it for the individual study ethics, and also to make sure that the study is registered. So all studies on real life data have to be registered. We register them with the European medicines agencies because they have a registry for real life studies. And so that it's transparent and in the public arena that's actually available. So hopefully that answers that question. So you don't have to apply for any ethics. That's the most important thing. We've done all the ethics hard work. I'm told Kerry's having a few technical challenges, so we'll keep going with some questions for this. What percentage of unstable asthma could be silent reflux? This is a really good question. I think there's a lot of hidden reflux out there. When people have done radiology on this and radio labeling, and you can see both the chest and the sinuses filling up with reflux. How often is that a problem, do you think? Who would like to give us a first go on that, Russell?
Well, I've had a Nissan's fund application. These seems to be partly my case histories on myself. I used to cough a lot with my reflux when it was really bad, but I never got wheeze, but I'm not asthmatic or atopic. So the problem to me is always, is it the acid or is it the mere presence of the regurgitated fluid in the airway? And all the PPIs in the world don't control the true volume refluxes. So certainly acidy fluid seems to be worse, but the mere presence of any fluid in the airway is what's promoting the asthma, I would presume.
Mm-hmm. And I'm with you on that I think, just giving a PPI is not an adequate test. No. Because it's liquid itself is bad enough getting in the lungs. It's irrespective of whether it's acidic or not. Acidic is worse. And in fact, there are a number of things else you can do from a pharmacological point of view. Metoclopramide, prokinetic agents may actually be quite helpful for some of these patients. And the cheap Gaviscons, etc., may actually also be extremely helpful before one goes to surgical procedures. I mean, Joe, what do you think on that?
Oh, there is that sort of reflux that comes up. The question is what percentage in that. But I do see some patients, a small percentage that don't have asthma with silent reflux that gets them wheezy and stuff. Mm-hmm. So I'd probably put them on a PPI and see how it goes.
I've got a really good question here about adult onset asthma and how common it is. It's actually about a new onset of symptoms in middle age, and people have thought about COPD because they don't think it's asthma at that age. I'll start maybe first, but we've been looking at new onset of asthma in our large UK data sets. And what you see is, yes, you see a peak in the kids, but then you've also got this increasing rate with age that actually was probably the original underlying pattern of asthma that probably occurred before we had all of the new surge of cases that occurred in the 60s, 70s, 80s, 90s. And it's probably an underlying pattern of disease that we still see in countries that have not had the same high asthma rates as Australia, New Zealand, UK. So you go to South Korea, there's very little childhood asthma. Whereas actually, that's where, so we've assumed that asthma is a childhood disease, where in fact it actually probably in history terms was probably more of an adult onset disease. I don't know what you guys think. Any thoughts on that? Russell? Joe?
One of my most difficult asthmatics was I did a 3-year research program back in general practice in northern New South Wales. It was 94 to 97, but our age group enrolled in our research was 6, and the oldest was 84 at onset. And the 84-year-old onset from Angara, she was the most difficult asthmatic I've ever managed. And if it hadn't been for the advent, I think, of Beclafort dosing in those days, we probably would have lost her. So yeah, my most difficult brittle refractory was in fact this elderly lady, and she had not had anything. The 2 sons smoked, but she'd never smoked. So it wasn't COPD. She just had very late onset asthma.
Yeah. And I think it's really important to think about that. Joe?
Yeah, I haven't got too many sort of late onset asthmatics, but obviously those with chronic cough, wheeze and things that don't smoke, I sort of think, yeah, they're out there.
Yeah. And many of them will have other pointers. Many of them will have a high EO count, eosinophil count, above 300. Many of them will also have nasal polyps. Always look out for that in those patients. And so just being aware of that, they often are quite difficult to treat. The good news is they do respond beautifully to the biologics. So in fact, I've got a final question here. How common asthma in elderly non-smoker? Actually, pretty common. And you can get new onset at any age in life. So just because somebody's 75 does not mean it's not a new onset asthma. And I think that's really important to have in your head. And someone from Tassie has said lots of adult onset asthma in Tassie. I wonder why they think that is. How to determine adult onset asthma versus cardiac asthma, heart failure? How do you tell the difference?
Well, you need an echo, and you need an echo that you can truly trust. And who should be doing those, radiologists or cardiologists? Well, that's a big debate for another day. But if you read the opening line of an echo, difficult study, technically difficult, basically, I believe you should put that echo result in the bin and start again.
Joe?
Well, I think obviously investigations like what Russell said will differentiate the two in some way, give you more information.
Yeah. And in the UK, we actually managed to get BNPs reimbursed, and they're a great rule out heart failure test. It's not a good diagnosis test, but it's a great rule out test. It's got very good sensitivity. And actually, when I was running my community respiratory clinic, which I don't do anymore in the UK, we would always insist that all new referrals had chest X-ray, spirometry, and a BNP, if not an echo, done before we actually assess them, just to make our lives easier. I've got a few questions about people who didn't get the details on the audit. We'll make sure we send you all about that afterwards. Don't worry. Apologies if you've not received that. I believe is Kerry ready to rock and roll? No, okay. Should you elevate the head of the bed for someone with heart failure?
Yes.
Does it work? Or does anyone do it?
Yeah. Most people end up elevating their head and not the bed. Those 3 or 4 pillows for either reflux or heart failure, but all they're going to do is give themselves a stiff neck. They don't actually alter the dynamics unless they actually elevate the whole mattress. Then you've got to work out without breaking the ensemble base in half how you do it. So, yeah.
Sorry.
It's in the textbooks, but I don't think it's very practical.
Yeah, no, I agree. If you raise the head of the bed, they just slip down, don't they?
Yeah.
I think there's another point here about beta blockers. I think it's a big discussion in itself, but non-cardiac selective beta blockers, of course, we've got to be extremely cautious with. But one point I will make, because we don't get to it when you're doing your talk on COPD, is we must still treat the heart failure properly. We've just published a show in the UK, patients with COPD who get heart failure get grossly undertreated for their heart failure. And I think that's a really big issue. So please do not treat the heart failure. Might be one of my messages.